researchers and rheumatologists here, and we're very fortunate to have two of them, really world-class rheumatologists with us this evening. And so I'd like to start off by introducing Dr. H. Michael Belmont. He specializes in lupus, is co-director, excuse me, of the Lupus Center. He's a pioneer in lupus diagnosis and management, and has been named one of America's top doctors by Castle Connolly for 10 plus years. And I know he's a physician for a couple of people who've mentioned it in this room. And without further ado, I'd like to turn it over to Dr. Belmont.
Thank you for that introduction. And I think Renee's going to advance the slides for me. And I'm going to spend about 30 minutes on a subject of great interest to me, that I think it should be for the audience tonight as well, which is the association between lupus and lupus in the kidney, or kidney inflammation from lupus, lupus nephritis, glomerular nephritis in the kidney. Those are all generally synonyms. So the topic is lupus in you for the night, and the kidney and systemic lupus erythematosus. Next slide. And my overall objective this evening is one where I'm hoping you as patients, any family, friends, and supporters of lupus patients will become aware and familiar with the kidney-related issues as they occur in lupus. And as we know, that's also called systemic lupus erythematosus, SLE or lupus. Next slide. And I have some very specific goals, although none of you, I believe, are medical students or physicians. I want you to understand the general principles of the function of the human kidney. We'll talk a little bit about how lupus can affect the kidney. We'll talk about what options are available should this kidney disease progress to complete kidney failure. And I'm going to say this more than once, that's what we want to avoid. When you're interacting with your provider, were you to ever have kidney disease, the one thing you want to avoid as best you can is progression of that injury to complete kidney failure. We will share a little bit with you who is most likely to get kidney disease, because not all lupus patients have a similar risk for the appearance of kidney inflammation. And we'll talk a little bit about treatment. So next slide. So you may or may not know, all of us have two kidneys. I should say, on rare exceptions, some persons can be born on a congenital basis with only one kidney. Someone could be in a serious accident and have to have one of their kidneys removed, but all of that is unusual. Most of us have two kidneys. On the right, and I guess on your left, you see they're located in the back, where the lower ribs are, and then on the right you see a larger picture of the left and right kidney, and in red you see those are the arteries that bring blood to the kidney, and then after it passes through the kidney, the remaining blood returns to the heart in blue. Next slide. But I think if you come to understand the function of the kidney as a filter of blood, you may understand, at least in passing, the nature of lupus in the kidney. So the kidney's main function is to filter the blood. In so doing, it removes waste, and that waste ends up coming out in your urine. And if you understand the photos here, the kidney, each one on the left and the right, are made up of 500,000 estimated microscopic filters. So I just picked two Google images of filters. Now, actually, in anatomy and biology, they're microscopic. Next slide. And these filters, and the fancy term is glomeruli, can be viewed as these holes in this strainer. And the problem in lupus is those glomeruli become filled by an inflammatory process, and over time they can become scarred, and they can no longer filter because they're no longer the equivalent of a hole in your filter or strainer. Next slide. And again, this is not intended for healthcare professionals, but this is just, in some basic terms, what happens when there's inflammation in the kidney. And this inflammation consists of microscopic complexes made up of antibodies to double-stranded DNA, as well as a protein complement 3, often abbreviated C3, as well as complement protein 4, abbreviated C4. These complexes of your own DNA, antibodies to your own DNA, added to complement 3 and complement 4, they end up going in those individual filters. And as a result, this process can be, is potentially reversible. And that's why early and effective treatment is important. But if there's a delay in treatment, or if the treatment proves to be ineffective, then those holes or those filters, those glomeruli are scarred. And this can become permanent. And if many of those filters, you don't have to have every last one be destroyed and scarred, but if a vast majority are injured, then you can progress to what's called total kidney failure. Next slide. And this is what we want to avoid. And I'm not intending to use a sort of scared straight approach, but I'm not sure everyone with lupus, and when they're told they have kidney inflammation, is aware that in the worst case scenario, you need to replace your kidney. And why is that? Because when you have complete kidney failure, it's not compatible with life. The reality is, it will vary, but prior to 1960s or so, when this dialysis, as you see on the left, became available, persons who had kidney disease, if you progressed to kidney failure, they would die. It would take some number of weeks and potentially months. But gratefully, again, since the 60s, we do have hemodialysis. But it's not ideal because, as you see there on the left, you need to have access to your blood, and you need to sit connected to a machine for 3 hours, 3 times a week. So I think we can all understand that's something we want to avoid. I show you on the right that there's an alternative to blood dialysis or hemodialysis. It's called peritoneal dialysis. And that's putting a catheter into your abdomen, and then you can put fluid in and out after several hours, or cycling it overnight, and it can also substitute for the kidney. But again, this is something, it's the goal of your treating provider and you and your family and your supporters to avoid this. But thankfully, it's available because it's life-saving. Next slide. And the reality is also, since probably the 1970s and increasingly available, should someone need to replace their failed kidneys, there are kidney transplants. And there are really 2 types. There's when you get it from a deceased donor, you generally are placed on a list, and based on the acuity, your comorbidities and your general health and the availability, you may get a deceased kidney donation. On the right, this is in the public domain. I think that's Selma Gomez, but she had lupus and had kidney failure, and she had a directed donor. You can get that from a family or friend if it's necessary, as long as they have the same blood type and have the general compatibility with your biology. Next slide. All right. But with that introduction, how does this all start? Well, an important point to be made about inflammation in the kidney is it's painless. And this is important because it contrasts with inflammation that lupus patients suffer in other areas. When a lupus patient has inflammation in the skin, you get a rash. And it's itching, it's maybe cosmetically unpleasing, and it's quite apparent. Similarly, if you have lupus affecting your joints, if you have inflammation in your joints, that's a painful form of arthritis. But the reality is, when there's inflammation from lupus in the kidney, there's no pain. The only time your kidney will be painful is if you have a kidney stone, or you have pyelonephritis, which is an infection of the kidney. Now, I'll repeat myself, when you have lupus in the kidney, it's painless. So the next bullet point underscores that means it's generally silent and without symptoms. On rare occasions, there can be swelling in the feet and legs, and this appears only if the amount of protein in your urine is extraordinarily great, such that it lowers the amount of protein in the blood. And it turns out, as a consequence, when you don't have enough protein in your blood, the fluid phase of your blood will leak out, drawn out often by the effects of gravity into your feet. So the point is, it's painless always. Generally, you're not going to have any symptoms, but occasionally you will have swelling, hands and feet. And occasionally you have foamy urine. So the normal urine does not have a lot of protein in it, but if there's an excess amount of protein, it appear foamy. And then on the bottom, on the left, and then on the right, you see pictures of foamy urine. On the right, there's the foamy urine here in a toilet bowl, and here's a toilet normal urine without protein. And when there's advanced kidney damage, Patients can experience severe nausea, vomiting, terribly poor appetite, and generalized swelling. And the fluid that's no longer being eliminated through the urine can back up and fill, let's say, in your lungs, in which case you'll become short of breath. And that's the progression of all that is why you need dialysis or transplant, because, as I said, complete kidney failure is not compatible with life. Next slide. All right, so the next question is, well, who's at risk for this kidney inflammation, lupus nephritis, lupus glomerulonephritis? Well, repeatedly now, over several decades, if you look at large numbers of lupus patients, amongst any group of lupus patients, about 50 to 60% will get lupus nephritis. So if we had 100 persons in this room with lupus, 50 to 60 at some point in their illness would have inflammation in their kidney. With that said, we know it does vary by some demographics. So LN, lupus nephritis, in fact, is most common in young males of color, but we also know the reality that 90% of persons with lupus are women and only 10% are men. But having said that, if you're a young male of color, you have probably a 60–70% risk of LN. We also know that lupus nephritis is more common in women of color. So the highest likelihood of LN are in persons of Afro-Caribbean, African-American, Black American ancestry, than Asians and Hispanics, all with a higher likelihood of lupus in the kidney than persons of European ancestry. Another issue is not all of our patients with lupus have antibodies to double-stranded DNA. The estimate is about 70%, 7 out of 10, 70 out of 100 persons with lupus will have double-stranded DNA. And it's those people who are at greater risk for kidney involvement. So if you're the 30 out of 100 that do not have DNA antibodies, the likelihood of kidney inflammation is not zero, but it's much less likely. I talked to you earlier about the manner of injury that clogs up those filters. It's DNA, anti-DNA, these antibodies to DNA, and making a complex with the third component of complement and the fourth component of complement. So patients with lupus who have low C3 and/or low C4 are also at risk, and they're about, again, as best we understand, about 60% of persons with lupus have complement consumption. The last point to be made is that kidney inflammation, as a general rule, appears either at the very outset of the illness, when maybe a fever, rash, and arthritis, or other problems outside the kidney related to your lupus, or within the first 2 to 5 years. Next slide. But the point we like to make in biology in general, in human disease, we have rules and there's always exceptions to the rule. And this is not intended to increase concern, but it's just a cautionary tale. The case is that there are some patients whose kidney inflammation does not appear until well after the onset of their disease. So you see there from the top, second and third, there's a patient whose lupus in the kidney did not appear until 19 years after her initial problems with lupus. The second patient was 17 years, another patient 15 years. There's one person in the literature who had lupus, and it wasn't until 34 years later that they developed this kidney inflammation. And the bottom four, actually, four persons in my practice, where it's a slightly different story. They had a long interval of time between their first episode and a subsequent episode. Now, I should report to you that this issue with kidney inflammation tends to be a relapsing, recurring problem. Just like your other issues with lupus, we often talk about a flare, right? You have an issue where at this time you're tired, you have rash, you have fever, you have arthritis, you have fluid around the heart and lung, you have problems with your blood counts. With treatment, you may improve, but the nature of lupus is it tends to recur. And these are just 4 cases where there was a long interval of time between episodes. So again, teaching point is there are certain persons who are at greater risk. It's usually early, but there are exceptions. Next slide. Now, once you've been diagnosed with lupus and you're interacting with your provider and you're recognizing, you'll know your demographics, your gender, your ancestry. You should know whether you have DNA antibodies, which you can ask your provider. You can ask whether you're C3 and C4. Well, your provider should, on a routine basis, and this varies a little bit by the risks I just described to you, but perhaps should be done no less often than every 3 or 4 months in the first several years after the onset of your disease, especially if you're a young male of color, if you're a female of color, or you have DNA antibodies, or you have low C3, low C4. So on each visit, which can be as often as every 3 months, they should do general blood counts and check your white blood cell count, your red blood cell count, and platelets. They should check your blood creatinine, which is a general measure of how well your kidneys are doing, and I have a slide about that in a minute. And they should also check in their blood test the amount of protein in the blood. And I will be saying this several times, but the major protein in your blood is your albumin. So those are somewhat interchangeable. Whenever your provider talks about your protein level, he or she most likely is talking about your albumin. The major protein in your blood is albumin. It makes up about 2/3 or 67% of all your proteins. So again, when you're seeing a provider, get those routine lab tests. You should get your antibodies to double-stranded DNA. Rising and high levels of double-stranded DNA are associated with kidney inflammation. None of these are 100% of the time, but if those levels are rising, that should raise something of a red flag, and you might need to be seen a little more frequently. On the other hand, the C3 and C4 are consumed, and they're lower in anticipation of kidney inflammation or during the period of kidney inflammation. On the other hand, the albumin, protein albumin, those are interchangeable, should also be measured. And a low albumin is a sign of kidney injury. And the next slide will address that. Not yet, though. I'm just pointing out, so you have the routine labs, you have antibodies to DNA, C3, C4, the blood protein measured as albumin. Then they should do a routine urinalysis. They can have you collect it on the spot. They can put a dipstick in it, look for blood protein and cells. But you should also ask your provider, especially if you're in these risk groups, to actually quantitate and tell you how much protein is in your urine. A normal person's protein in relationship to that creatinine is usually no more than 200. And we get concerned when it rises to 500, certainly over 1,000, and it's very dangerous when it's 5,000, 10,000. I think the highest I ever had was 45,000. But these are the tests that you should be asking to be performed during your encounters with your provider. Next slide. All right, so this is complicated. And again, there's no exam at the end of this. But it talks about the inverse relationship between the creatinine in your blood and the protein or albumin. And the protein or albumin can both be measured in the blood and the urine. What you see on the left is with a healthy kidney, you should have a low blood creatinine. You should have a high blood protein or albumin, and you should have very little protein in the urine, under 200. On the other hand, on the right there, if you have an inflamed or damaged kidney, the creatinine in your blood will go up. The amount of albumin or protein will go down in the blood, and that protein or albumin will appear in the urine, so it will be high. And really, the next 2 lines there give you an explanation. Creatinine is produced by muscles. Now, admittedly, if you're a bigger man, you'll have more creatinine than a smaller woman, but in either case, whatever creatinine is made in the blood moves to the kidney, and if the kidney's healthy, it'll pee it out. So if your kidney is damaged, that creatinine will go up. On the other hand, in an inflamed and damaged kidney, the protein and albumin spills out. So high creatinine is bad, low albumin is bad, and the contrapositive, if you have a low creatinine and have a high albumin, that means the kidney is doing what it's supposed to do. And this all goes back to those filters I showed you, where the job is to get the creatinine out and keep the albumin in the blood. All right, next slide. All right, so again, this is not something you'll be tested on, you have to memorize, but we do have a classification when you have lupus in the kidney, which is based on the kidney biopsy. And there's 1, 2, 3, 4, 5, 6 is very advanced, and you be unfortunate if that's what's found in biopsy. And it turns out that 4 and 3 are worse than 1 and 2, and 5 is intermediate. And again, nothing for you to memorize or be tested upon, but I think an educated patient can always advocate for themselves. And I do think when you have a biopsy, you should ask your doctor, hey, they'll often tell you, well, why are you doing a biopsy? 1, to prove that you have lupus and to see how serious it is, how advanced it is. and what class it is. So you should be familiar. Well, I had class 1, I had 2, I had 3, I had 4, and you can have combinations. You can have 3 and 5 or 4 and 5. Again, not for you guys to memorize, but it's something you could have, recorded for yourselves. Next slide. This is what is provided on a biopsy. You see at the top those various classes I spoke to you about. I'm mostly sharing this with you. These are one of the filters. That's under high magnification. But if you think back to the earlier slide where I showed you a filter and a strainer and a colander, that's what they really are in biology. The blood goes into there, and the kidney's healthy. It does what it's supposed to do. It gets rid of the waste. It allows it to go into the urine. But if the kidney is damaged, the creatinine can't get through it, and unfortunately, too much protein in the albumin falls out. And this is actually immunofluorescence. Again, nothing to memorize, but that's evidence of that antibody to DNA in C3 and C4. Next slide. And this is just what are the goals of treatment, and again, I'm just highlighting some areas. We don't have time to go into depth. But generally, patients who have lupus in the kidney have increased protein. I've spoken to you about that repeatedly. And there's a goal that within 3 months of treatment, whatever the protein was, you want it to be reduced by 25%. At 6 months, you want it to be reduced by 50%. And then by 12 months, you want it to be under 700 or 500. So if you think about it, if someone had normal is only 200. That's the amount of protein a normal person would have in the urine. But if you were a lupus person and it was 4,000, by 3 months you want it to be 3,000, by 6 months you want it to be 2,000 or less, and by 1 year you want it to be under 500 or 700. Next slide. And this is just, we talked at the outset about who is likely to get lupus in the kidney, and it's persons of certain ancestries, Asian, African American, Black, Hispanic. If you're, that's that creatinine I told you about. If you have a damaged kidney, then that creatinine goes up because it doesn't fall through the filter. The nephrotic range proteinuria just means proteinuria over 3,000. Younger persons, this is class 4, young men, and then things like lack of access to medical care, high blood pressure, being overweight, and diabetes are adverse for the outcomes. Not getting a biopsy should one be needed, and poor response to therapy. And again, this is not to scare people straight, but unfortunately, even as 2023, the best prognosis we can give is that 20%, which is 20 out of every 100, 1 out of every 5 persons with lupus that have kidney inflammation very well may progress to that kidney failure within 15 years of the onset of their kidney inflammation, and then have to rely on the dialysis or a transplant. Next slide. So, a summary to this point, kidney involvement about 50%, but increased risk in persons of color, about 20% progress to kidney failure, and the goal is to reduce the amount of protein in the urine. Next slide. Now, are there treatments? And again, this is nothing to memorize, but I've been a rheumatologist since 1985, and you see the year some of these studies were published in the medical literature. But since 1986, cyclophosphamide has been used to treat lupus in the kidney. More recently, mycophenolate mofetil, and then most recently, adding aluminate, mycophenolate, or voclosporin to mycophenolate have improved outcomes. Next slide. And this is really more for medical practitioners, but it makes the point on the left, when we talk about lupus in the kidney, you want it to be diagnosed earlier, better than later. And when you treat, we talk about the first 6 to 12 months. I gave you that data that you want it reduced by a certain amount at 3 months, 25%, reduced by another amount, 50% at 6 months. You want the protein under 700 or 500 by 12 months. That's the induction window. But studies show if you stop treatment at that point, there's a high likelihood of things getting worse. So we generally maintain treatment for an additional 1 to 5 years. All right, next slide. Now, this is an important slide just for the top, and our doctors and as providers and our patients struggle with this. Every drug has 2 names. And sometimes the provider is using the generic and the patient the brand and vice versa. And it's a problem. It's a problem for practitioners, for trainees, nurses, and for our patients. But these are the drugs that are used to treat lupus in the kidney. Many are used to treat lupus outside the kidney. Hydroxychloroquine, the brand is Plaquenil. There are various steroids. Prednisone is deltazone, medrol, methylprednisolone, and salmeterol is an IV form. Mycophenolate mofetil is Cellcept, 500 milligram tablets. Mycophenolic acid, MI40, 360 milligram tablets. Azathioprine or Indirem, 50 milligram tablets. Cyclophosphamide, generally given IV, although there are oral tablets. Rituximab is IV. Tacrolimus is Prograf is a pill. Lupus or voclosporin is a pill, and belimumab is injectable. Next slide. So I'll just quickly go through each of these. All persons with lupus probably should get hydroxychloroquine, whether you have kidney involvement or not. Studies show there's less joint pain, less rash, less fatigue, less blood clotting, less kidney inflammation, less mortality. It's generally safe and well tolerated. It's a long-term drug. Very rarely you can get a rash when you start, in which case you may have to abandon it. And the main risk occurs late, many times only after 6 or 7 years, or if it occurs at all, it's usually after 6 or 7 years, and even that is infrequent. So that's why you're told when you take that drug to get a baseline eye exam and then an eye exam once a year, just to screen for this rare adverse effect on the retina, which could affect the quality of your vision. And extraordinarily rarely, and again, very late, the drug sometimes has affected hearts and nerves. All right, next slide. Now, steroids, there's the intravenous forms, which are often used when you're in the hospital or for a few days when you're first being treated for your kidney inflammation. But generally, it's an oral medication. It's rapid acting. It's one of the most effective treatments we have. But it also has the most side effects. And that's why we talk about a goal of using the lowest effective dose for the shortest period of time. You want to get real bang for your buck when you're on it, but you want to get off it as soon as you can, because it'll increase your appetite, you'll consume calories, you'll gain weight, you get an increased blood sugar, you can get frank diabetes. It has adverse effects on your bone, either osteoporosis, which can lead to fractures, or this other problem in lupus persons, especially where the bone sort of collapses and gives secondary severe arthritis. There's also an association with the higher doses of steroids with infections. And some patients find it in a manner that they appreciate, where they feel a little better for being on it. But on the other hand, many persons with lupus on steroids will become sleepless and agitated. Next slide. All three of these are pills, and they're very similar. They're purine antimetabolites, but they inhibit the cells that make the DNA antibodies. These are all pills. They all share the potential to lower your white blood cell count and increase your risk for infection. They can also reduce your red blood cells, giving you anemia and fatigue, or reduce your platelets, which is the risk for bleeding. You need to have your liver blood test monitored. Occasionally, they can give you nausea, or abdominal cramps, or diarrhea. There's a minor increased risk in skin cancer. And both mycophenolate and mycophenolic acid are not to be taken in pregnancy because they cause birth defects. But as I put there, it's only if you take the drug when you're pregnant. So you can take the drug and then stop it and move forward with the pregnancy, and it doesn't affect the fetus. Next slide. All right, cyclophosphamide, we mostly use the intravenous form because overall we think it's safer and more effective. There are two ways to use this drug: a very high dose once a month, or a very low or a lower dose every 2 weeks for 6 treatments. This drug also can lower blood counts. There's some association of this drug with bladder injury, can produce infertility and very rarely sterility, but this may be limited to the higher doses given monthly and may not be an issue when you get the lower doses every 2 weeks. It does cause birth defects, so you don't take it if you're pregnant, and also has a small leg cancer risk. Next slide. Then there's tacrolimus and rituximab. Tacrolimus are pills. It's been around for a while. It's not actually approved, but it's often used off-label until the drug, which is similar, now approved by the FDA, voclosporin or Lupus. It's generally used with MMF or mycophenolic acid, although it can be used alone. You see the recurring themes here: infection, lowering of the blood counts, but that drug, tacrolimus, is safe in pregnancy. Rituximab is used intravenously, generally by rheumatologists, 2 treatments spaced out 2 weeks apart and then every 6 months, often used with MMF or mycophenolic acid or cyclophosphamide. The main risk of this drug is, while it's actually being infused, having an allergic reaction. Next slide. This drug was approved in January of 2021, voclosporin. It's a calcineurin inhibitor. It's the third in a family of drugs that's been used for a long time to treat lupus, cyclosporin. The prior slide showed you the tacrolimus. Now we have the voclosporin. However, this is probably the best in class to treat lupus nephritis. It's actually FDA approved. You do have to generally take 3 in the morning, 3 at night, often in combination with the CellCept microphenotyl, but it's clearly more effective than using the CellCept alone. Studies that my colleague, Dr. Saxena, has presented to the medical community has demonstrated that these benefits seen with the drug have been sustained for 3 years, small risk of infection. And it's currently not approved for pregnancy in part. There's microscopic amounts of alcohol in the formulation, but it's really similar to drugs that are safe in pregnancy, and they may be formulated in the future, so you don't have to discontinue it at the time of pregnancy. Next slide. Avelumab, this is available either once a month IV, or at home you can self-administer it weekly. Again, often combined with MMF. It's been around since 2011, originally for arthritis and rashes, but more recent studies demonstrated improvement in kidney outcomes. It has minimal risk, but the fact is belimumab with MMF may not have the same potency and efficacy in lupus nephritis as, for example, MMF and voclosporin, especially when it comes to persons of color or if there's very large amounts of protein in the urine. Now, all those drugs are intended to treat the DNA and the complement in your immune system. But when you have lupus inflammation in the kidney, you should also take a medication that's intended simply to reduce the protein that's spilling out into your urine. These drugs don't reduce the inflammation, and they consist of 2 families, the ACE inhibitors or the ARBs. They're somewhat interchangeable. You usually get one, not of either class, but not both. But you should be on lisinopril and alcohol, ramipril, or losartan, tomasertib, and valsartan. Those are not exhaustive. There are additional ACE inhibitors or ARBs, but these are the ones that are used most commonly. Now, people sometimes say, oh, my pharmacist said this is only if I have high blood pressure or heart failure. But the fact is, even absent high blood pressure or heart issues, these drugs should be used when you have lupus in the kidney and they reduce the amount of protein. And I told you, getting that protein down at 3 months, 6 months, and 12 months is your goal. There are some risks, mostly lowering your blood pressure, in which case you might be lightheaded. They can increase your blood potassium, and your doctor will manage those. And these drugs are not approved in pregnancy, so they need to be stopped. Next slide. So we're about to conclude now. I told you that unfortunately, despite all the education I'm sharing with you and the education of us as providers, there's still 20% of patients who may progress. But is there reason to be optimistic? Yes, there are many future treatments of that being explored, and my colleague, Dr. Saxena, will be talking to you about clinical trials, and that's how we move forward. I showed you in the 80s, we were using cyclophosphamide, then MMF in the 1990s. Now, more recently, we're using the belimumab and the voclosporin. Next slide. All right, so what are the take-home points? Know if you are at risk for kidney involvement, young men, young women of color, DNA, C3, C4. Remember that this problem is painless. So I always remind myself and patients, hey, when you have fever, when you have a rash, when you have arthritis, you run to me. But when you have kidney inflammation, you're not going to know it. The only way to know is to check your blood work, check your labs that I spoke about in your urine. So it's important to adhere to your medications and need for close monitoring, including these blood and urine tests, because you're going to be painless, silent, and asymptomatic. And when one of the groups of patients that we're worried about who will progress potentially to complete renal failure, those in whom it's hard to control their blood pressure, when we can't get that protein reduced in the urine with our medications. And I spoke to you about the reality. Some persons are lucky. They have one episode and it never comes back, although you do need to monitor everyone. But persons who have frequent recurrent episodes accumulate injury. You think of, with the first episode, you may lose 10,000 of those filters in each kidney. And the next one, you may lose 100,000. And the third one, you lose 300,000. And that's what really jeopardizes your situation. So very rarely you can have such bad kidney in the beginning that despite best efforts, you need to start your dialysis. But most of the 20% that have that problem, that only occurs at about 10%. And the vast majority is because over the years, this issue keeps coming back. So blood pressure control, inflammation control, protein control, take your medications and see your doctor. Okay, I think it's going to be time for questions. Right?
I started with the Lupus Foundation almost 8 years ago, and my first education program I ever did. Dr. Saxena was our speaker, so this is kind of a fun full circle moment for me. He's an academic rheumatologist here at NYU Langone. He's the director of lupus clinical trials and has been the site principal investigator in over 30 industry, NIH-sponsored, and investigator-initiated interventional and observational trials. He is also the co-director of the Clinical Trials Design course for the NYU Master of Science of Clinical Investigation program. He is currently studying the safety of the shingles vaccine in lupus patients. And I know he's also a physician to a number of people in the room. So without further ado, Dr. Saxena.
I want to thank everybody for coming, taking time out of your weeknight to be here with us. And it's going to be a hard act to follow with Dr. Belmont. I really am just in awe of how much information you were able to cover in such a short period of time. And I figured that you would, because you have to talk about nephritis, talk about a lot of kind of nitty-gritty details. So what I wanted to do more with this is really just kind of take a little broader aspect in how we study lupus and how we get to the point where we can get new drugs for trials, and talk about clinical trials in general, and talk about them in relation to lupus, and then talk about where we're going from here. So you can go ahead with the next slide. All right. So here's a question. What's a clinical trial? You throw this word around and you think about just research, and there's ideas that you can do research in a lot of different ways, right? You can take a group of people and look at what happened to them in the past and see what makes one group of people different from another, but that's not a clinical trial. That's more kind of an observational trial. A clinical trial really is something that we say is prospective, which means that we start at one point and we follow people going forward. And we compare what happened to some people who get some sort of intervention versus some people who get either no intervention or just kind of the usual stuff that people get. And then we compare them. We see to the people who got whatever intervention that is, and usually we talk about drugs, but that's the thing that we think about when we talk about clinical trials, but it doesn't have to be a drug. And we talk about that and we compare them and we see, did this intervention do something that doing the regular things didn't? And so that those interventions can be anything. It could be a diagnostic test to see if we look at this one blood test, it shows that some people have worse disease than another. It could be some sort of preventative measure saying if you take this vitamin or take this diet, will that prevent things from getting worse in the future? But the most common things that we look at are treatments, right? We look at medications often or other types of things that we can do to make people feel better. And the key to doing these interventions, whatever they are, is that everybody in the study gets the same kind of treatment, right? So everybody gets either the drug in the same way or the placebo in the same way, so that nobody knows what's going on or what they're getting, so that we have the most unbiased way of looking at things at the very end. And so when we talk about the group of people that get the intervention, that's going to be a certain percentage. A lot of times it's 50-50, but it doesn't have to be. And then there's that other group that gets put into what we call the control group. Those are the ones that are, that get everything the same, except that instead of whatever that drug or whatever that thing is, they get, a placebo or something. And the key to comparing people in a trial is that everybody who gets the intervention, everybody who doesn't, are pretty much the same otherwise. That way you can say, this is a group that's so similar that we can only attribute any sort of differences to whatever it was that we gave them, whether it's a drug or something. Okay. So we'll take a little bit of a historical look at what clinical trials are, because it's kind of amazing. We think about science, is that, how we've gotten to this point where we do these trials, it's not an ancient thing. There have been very smart people for thousands of generations, but the idea of how to do these clinical trials is actually a pretty recent thing. And one of the things that people talk about as maybe the first ever clinical trial was a study on a boat regarding scurvy. So if you know anything about scurvy, it's a vitamin C deficiency that leads to all sorts of problems with your skin and your bones, and it really can cause problems in people who don't get enough nutrition. And so the place where we would see this happen all the time is when people would take long, boat trips across the Atlantic. And so there was always this question as to what this was. Nobody knew what caused this. And there was this doctor on this boat named Lind who had this idea that maybe it had to do with vitamin C. And so what he did was, there was a bunch of people with these symptoms, and he gave each group of people a different, treatment that he thought might work. And some of them were things like vinegar, and some of them were whatever medicine or snake oil they were using before. Another group of people were given oranges and lemons. And those people who got the oranges and lemons did really well. And so that's the or limes, and that's what you ever hear people call pirates limeys. That's because they always would have limes in their mouth to prevent, scurvy from happening. And so that was the idea, that this was like a trial where you're comparing one group of people who got one thing versus another group who got another thing. And so from that, we've kind of moved forward to understand the best ways to actually study things. And so in doing so, we talk about all these different things we try to do in trials. And so one of them is something that we call randomization. So that means that whatever group that you get put into, whether you're getting the drug or you're getting the placebo, it's by chance, So if you go back, the first time this happened was, again, not that long ago, 1931. They were doing this trial on tuberculosis, and they were literally just flipping a coin to see who got into each trial. And so that is, again, randomization. And that's important, obviously, because you don't want, there are all these things that make us different, that are whether they're our weight or prior medical history. And if you put people randomly into groups, you kind of randomly put those other aspects into those groups too. So you'll get the same number of people who are whatever weight in one group and another. So that's why we do that randomization. Then we do this thing called blinding. Blinding means that the patient doesn't really know if they're getting the drug or not. Because sometimes when we do clinical trials, we ask patients how they feel. And if they think they're getting a drug, they will say, I feel great. And it's just a thing that happens. We know that happens. It's human nature. And so that was introduced in another TB and cold vaccine trials where they would use these injections of either water or saline, and the patient wouldn't know what they were getting. And so then we move to what we call double blinding. That means the patient doesn't know, but we don't know either. Because the truth is, we also have biases. We have things where we say, maybe it's getting better. Like, you really want your patient to get better. And so if they're getting the drug, you might say, yeah, totally, they're totally getting better. The drug is awesome. And so that's a bias, and we don't want that. So that way, whenever anybody's in a clinical trial, I don't know if they're getting a medication, the patient doesn't know if they're getting medication, and in the end, we're just going to see how they do. And so that's the best case scenario. So if you just click one more, that means what we call the ideal trial is a randomized, double-blind, placebo-controlled trial. That means that all those factors that we talked about are there. So sometimes that's not possible. Sometimes you have to know if you're doing a drug where it's impossible to hide it. We know that. It's not always perfect, but a lot of these clinical trials that we talk about where we actually get drugs approved, this is the type of trial that we use. So what makes a well-designed trial? And so as we talked about, unbiased assignment to the treatment, right? A lot of times you might say, if I had my way, a really sick patient comes in, I might say, I really want this person to get the drug. I don't want them to get the placebo. And so if you do that, though, you're totally biasing the people who got the drug to those people who are really sick. And so that way it has to be a bias. It has to be random. Okay. Got to have a lot of people. The more people that you have in these trials, we call it power. The more power you have in the study, with the more people in a trial. And it becomes very obvious when you have a few people. Any one person who does well or doesn't do well changes the whole outcome of the study. So if you have enough people, you can say, this many people are needed to show that you have enough power to discriminate whether or not your drug is working or not. And so that's the numbers. And so when that comes down to what we do, when we're coming up with these trials, trying to decide how many people are going to be in these trials, and it's not as easy as just saying, oh, let's just get 1 million people into this trial, it'll be awesome. But it doesn't work that way because, as we'll talk about, patients are limited, and also funds are limited. The more people you have in a trial, the more expensive it is. So drug companies who are sponsoring these trials don't have unlimited, as much as it seems like they might, they don't have unlimited funds to do these trials. And so figuring out how many people go into these trials is, in a lot of ways, the most important thing that actually they do. Next step. And so then we need to have objective and reasonably complete assessments of the outcomes. And this is where things kind of fall apart in our disease. So we'll talk about that some more. But it's easy, let's just say if you were doing a trial in blood pressure, right? You can say the outcome is, did we lower your blood pressure? And so when we talk about things like that, or diabetes, where we're trying to lower your blood sugar, it becomes very obvious that those are objective and complete assessments, and that's great. Lupus, as you guys all know, there is nothing that is easy about lupus, and nothing that is complete about it. So we'll talk about some of those foibles coming up. And then, of course, from our end, again, you have to do a proper analysis. And this is where, when we're reading papers as doctors, we can say, oh, they totally fudged this, and they really tried to look at things in a way to make themselves look good when they really weren't. And so that's part of our idea of measuring these things. And that's when papers get sent to journals, experts have to read them and say, oh, as peers, we review this and say, this is a good idea, this is a good way they did it. And so one of the ways we do that is we make sure that we're looking at what happens to people in these trials by counting everybody. Like a lot of times people feel like, oh, let's just get rid of all the people who dropped out of the study. They didn't take the medicine for the whole year, so they shouldn't count. But if you do that, then maybe if they dropped out because their drug caused terrible side effects, you're not counting those people, and then you're not showing that, what the real life implications of using the medication is. So these are the phases of clinical trials. This is what you probably hear about when you hear about like studies in the news. They'll always talk about this was a phase whatever. And so phase 1 is usually either healthy volunteers or affected patients, but it doesn't really matter how sick they are. And so this is the way that we kind of estimate, is a drug safe? That's really the best way to show that it's a drug safe, and also how much of the drug can we give to people. And so a lot of times we don't do phase 1 trials like in a hospital setting. Sometimes we do, but a lot of times phase 1 trials are done in like these big institutions where all they do is phase 1 trials, and they do like trials for like tons of different diseases, and they keep people in their hospital, and they check their blood every 10 minutes looking to see what's going on with them. So in a lot of ways, most of you guys will not be exposed to phase 1 trials, but it's still possible. Phase 2 trials are really one of the first things that we do here in our site and most other trials. And here we're really looking at patients who have the disease. And we're still trying to figure out how the drug works in patients who have the disease, what their biologic activity is. But it's more in this kind of clinical trial aspect that we talked about, where we're controlling when people get a drug versus a control group. Sometimes you might do it versus other types of pretreatment groups, but not so much these days. And a lot of times these phase 2 trials will look at like multiple doses in a drug and to try to figure out what the best dose is. And that way, when you do one of these trials, it's not always like 50-50 are you going to get the drug. A lot of times it's like 20% get one drug, 20% get one dose, another 20% get another dose, like that. And then there's still a placebo group to kind of compare against. And they'll use those results to decide, should we move forward to that phase 3 study? And that phase 3 study is kind of the one that you usually hear about. When a drug gets approved and it's in the news, it's usually because it passed the phase 3 study. And that's a study that really looks at affected patients. Again, a major outcome is the effectiveness. Still looking at safety, but really the effectiveness is the most important thing. And then you're examining those adverse effects, but still these trials are relatively short, so it doesn't tell us what the real world aspect of the side effects of these drugs are. But that's what you need to get the FDA approval, have them come up with that fantastic brand name so that you can remember what it is, that only what happens when you get to that kind of phase 3 level. And then phase 4 is actually the thing that people don't talk about, but is actually in a lot of ways the most important phase, because that's what tells what happens in the real world. Once you get the drug out there, and way more people are taking it than were in those trials, that's a lot of times when we find out, oh, there was a side effect that we didn't know about. Things like that happen. And we use these phase 4 trials to really show what the real world is. And sometimes they'll use it to compare it to like a similar drug, or to get it in a different disease that maybe wasn't like approved for the first time. But it's great because these are used in the real world, you'll get those larger sample sizes, you'll have more power, and you'll really do a better job of showing how well a drug does compared to those big phase 3. So lupus. So the major obstacle to drug development in lupus is obviously just lupus, because lupus as a disease is very difficult to study. So you guys know this, but not everybody with lupus-like symptoms might have the full criteria of lupus. Right? So you can feel like crap, and you can, be told by your doctors, hey, look, this seems like lupus. I think this is lupus, but you might not tick off all those boxes of lupus. And from our standpoint, when we're treating, we try not to treat people differently, necessarily. If we think that this is lupus or it's similar enough to lupus that we treat, we would still treat. But people like that might not meet that criteria to get into a clinical trial. And from this trial standpoint, it makes sense, right? You don't want people who don't have a disease, actually in your trial. It's always hard for patients because the patients who sometimes are feeling worse don't meet those criteria. And so sometimes it stinks because people will come to me and say, I want to be in a clinical trial. And I say, I can't actually put you in a clinical trial because you don't meet the criteria. But that's one of the things about lupus that makes it difficult to study and also limits the number of people that are out there available to be studied. It makes it hard to get all those trials. The biology of lupus is different in different people. Dr. Belmont talked about the double-stranded DNA and that's all, right? Some patients have those antibodies or those blood tests and other people don't. And it's partially because their biologies are different, but they still have lupus. But then how do you compare those two people? How do you compare people who have that biology versus people who don't? It becomes very difficult. And so that's part of the reason why it's kind of hard to get true answers. And then probably most importantly, as you guys know, the clinical expression of the disease is totally variable. One person has joints, one person has skin, one person has kidneys. How do you put all that stuff together and compare them? Say you got better with your joints just as well as you got better with your mesh. It's really difficult to do. And then finally, the fact that the disease, as you guys know, it's a rare disease, comes and goes. If it gets better while you're in a clinical trial, was it because your drug worked, or was it just because you got better? We don't know. And so it's one of those things that becomes very, we bang our heads against the walls trying to figure out, did the drug work? These trials. So you try to come up with these ways of measuring these things. So there's been a lot of treatments, a lot of ideas, and what's really great and what separates out now from 20, 30, 40 years ago is that we have a greater understanding of what's wrong with patients with lupus, why chemically are some people different than others. And with that comes ideas that, okay, if we block this problem where you have inflammation, maybe we'll stop the inflammation. And so over the years, it's been all of these targets and all of these drugs that have been made. And if you click on that again, Renee, you'll see that the vast majority of them have been, and it's not because these were not always bad ideas. Sometimes things just don't work. Sometimes the trial didn't work. The trial wasn't done well. And so, but the unfortunate reality is that we've had way more failures in trials for lupus than we've had successes. Go ahead, next. Keep going. There's a lot of X's. There's much more. One more. Going. All right. So I'm just going to talk a little bit about what some of those foibles are in trials of lupus again. And again, this is not to get you down. We're going to get into the part where I've been successes, but we talked about kind of those inclusion criteria. What gets people into a clinical trial? And so again, we talked about people if they're included with average group diagnosis with lupus, or if they come in and they're not really that active, it becomes hard to separate out because if you're not really that sick and you get a drug and you don't really get that much better, you can't really see the difference. You can't see that the drug actually worked. And us trying to decide who is really sick is not easy, even for people who consider themselves experts. Dr. Belmont will know a lot of times in our clinics, we'll all sit in a room together and say, hey, do you think this person has active arthritis? And like half of the people will say yes, and half the people will say no. It's really tough, and it makes it really hard for us to really kind of document, what's different between patients. And then even just finding patients with confirmed active lupus is difficult. Again, like we talked about, some people, just have mild disease, or they just have, they have symptoms that are very much like lupus but don't meet the criteria. And so when that happens, you can't get enough people to do the trial. And when you do, you use that power. Again, you can't really confirm that difference. Then we talk a lot about background medications. This is another issue that we have with lupus trials, is that, the majority of our trials don't fail because the drug part of it didn't work. It's actually because the people who got the placebo did better than we expected, and you can't really see a difference. And so why? Why does that happen? That makes no sense, right? People are coming in and they're sick. But I think a lot of that has to do with the fact that when you go into a trial, ethically, as you should, they let people take the medicines you were on before, because you want to pull something away and make somebody even worse. But maybe when that happens, people start taking their medicines more often. We all miss doses for sure, and maybe when you're in a trial and people are watching you, maybe people start taking their meds a little bit more often, and then actually works a little bit better. Again, maybe it's just that their disease got better on its own, because that's what happens sometimes. But whatever happens, we always see these like way higher levels of the placebo arm than we expect. We think that those people would do really bad. A lot of times we allow people to use steroids. Steroids make people feel better. So in the end of the trial, if you've been using steroids the whole time, you're going to look like you did good, even if you got the placebo. So that's why some of the more recent trials are kind of saying, you've got to get rid of the steroids. It's mandatory. That way we can tell the difference. Next one. And then the disease activity measures. This is the outcomes. And so I put this picture up here because without getting into the details of this, is that we think about the way that we measure lupus, and a lot of it is kind of like the New York City subway. It's a plaster job. We come up with this idea of how we're going to measure lupus, and we say, let's do it in a trial, and then it doesn't work. We're like, oh, it didn't work because we didn't account for this problem. And then we put a plaster on it, and we say, okay, we're going to make another assessment where we account for that. And it goes on and on and on. And now every time we do a clinical trial, we have to do like 50 assessments to try to cover all of these different things, and none of them really work. And really that has to do because the disease is just so different from different people. It's super heterogeneous. And there's a lot of subjectivity in terms of who's deciding if a patient got better or who didn't. So next slide. And so all that said, all of these failures, and it's been super frustrating, we are moving forward. Things have now been approved. In the last 10 years, at least, we've had 2 new drugs for non-nephritis, and we've had 2 new drugs approved for nephritis. And so we're going to focus, because it's a nephritis trial, just very briefly. I'm not going to give too much data, but we're going to talk a little bit about a couple of those trials that we had mentioned before about nephritis. And in a way, studying kidney disease is easier than studying lupus in general, because when we talk about lupus in general, we talk about rashes, and did the rash get better? I don't know, maybe yes, no. Did the drug get better? I don't know. Nephritis at least gives us numbers, right? We've got the protein in the urine, and we can compare, did it get better from the beginning to the end? And so when we talk about what it takes to get into a clinical trial, it's pretty straightforward. You have to have a biopsy that shows that you have active lupus nephritis, and you have to have a certain level of protein in your urine. Remember those numbers that Dr. Belmont mentioned? Usually we talk about 1,000 or maybe 1,500 for that number to start. And pretty much everybody gets the same medications in the background, which is usually that medicine that was the mycophenolate, the Cellcept. And while you have to use the steroids, again, ethically, we're treating everybody the way that they should otherwise. We do make sure that those steroids are tapered so that we can see, does that, do people separate out? And the disease activity measures are easier to measure because you're literally just measuring the amount of protein in the urine. It's not a question of did the rash get better, did the joint get better. But still, there's a question even with that. There have been some debates as to what is the right number? Is it 500? Is it 700? So there's still some differences in that regard. And again, that's stuff for us to nerd out about when we're having our debates amongst rheumatologists. But it's still not the perfect way to go about it. So we'll talk very briefly about these 2 clinical trials of these 2 drugs that were approved relatively recently. So this is belimumab. This is the brand name is Benlysta. And as we talked about, it was a phase 3, that's the big one, randomized double-blind placebo-controlled trial. And when the trial was done, there was only the IV infusion version of this. Now they have a one that you can take at home. But they studied the IV infusion and they compared it to placebo. They compared it to standard therapy. So everybody got steroids, everybody got mycophenolate or cyclophosphamide. And it was a longer trial, it was over 2 years. And you can see there's 448 people on here. That was actually a pretty big trial for us. That's a big lupus trial. And they made sure that everybody who got in, as we talked about, either had, over 1,000 on the protein and the biopsy showing the lupus nephritis. And they came up with this, response, composite essentially to say, did you respond? And again, you don't have to know all this stuff, but you go ahead and click on next. And so as you can see, there were differences. Sometimes you look at those bars and you say, there's difference. It's statistically significant. Is there a huge difference? Well, yes, in a way you have to think about it, because when you look at those placebo rates, and what we're talking about is just the percentage of people who have got a complete response. And even if you just go from 20 to 30 or 30 to 40, that's more of a chance getting a response. And as Dr. Belmont talked about, getting a response means potentially not being on dialysis, potentially not needing kidney transplant. And so this was the primary outcome. It showed a statistical significance difference between the people who got belimumab versus those who didn't. And there were similar safety profiles. It's not like that made people have more side effects putting those two drugs together. The infections, which is the one thing we always pay attention to, because these drugs are immunosuppressing, they increase your risk of infections. They were balanced, in the same, essentially, and deaths in the group were balanced between the groups. So the safety seemed to be good and the efficacy seemed to be good. So with that, it got approved for nephritis, and now we use it, in combination with standard therapy. Voclosporin is the other one. Oh, just double. You can click again. I think. Oh, never. Sorry. Go forward. Click again. Okay. So voclosporin is the other one. This is the brand name is called Lupus Nephritis. And so this is the study, which again was a phase 3 randomized double-blind placebo-controlled trial looking at this drug voclosporin, which is given in this dosage 3 tablets twice a day, or placebo, again in combination with the standard therapy, which is going to be that mycophenolate and your steroids. Similar inclusion criteria, a little bit higher levels of protein to get in, similar primary endpoint. And again, you can see here, there's a statistical significant difference. More people who got the drug than that didn't get the drug showed a complete renal response. And the time to getting a good response was faster in the people who got it. And so this was approved. All right, so I don't want to bore you too much with all this data, so I'm just going to end by talking a little bit about what is lupus clinical trial, what to expect as a clinical trial participant. And so, the benefits are the potential to have access to treatments that may have a better response rate than the standard of care. And so we think about, even with these drugs that I just showed you that have these good responses, those response rates weren't fantastic, right? We're talking about 40%, maybe 50%. We have a ways to go. We want a drug that will do 80%, 90%. So we're still doing these trials. That's not the end all be all. We love having more options, but we need to do more trials. And so if you are the type of person that's either failing the prior treatments, or just know that, hey, I want a better shot potentially of getting a response, then that would be a placebo. That would be a clinical trial. Some people still might get a placebo, but then in some trials, after a certain amount of time, they give those people the drug also. In addition, when you're in a trial, patients are evaluated thoroughly. Obviously, make sure they meet criteria, but you get a lot of hands-on care in a clinical trial. There's always going to be there's visits every month, and all this constant communication, and you get really kind of a different level of care than when you're doing a clinical trial. Very close monitoring, frequent visits, frequent testing, and obviously you just get the potential to help move the needle, move things forward. And certainly there's plenty of reasons to not do clinical trials. If you don't want to, you don't have to. No, I'll ever let anybody ever pressure you into doing a clinical trial. Of course, there's the historical things that we think about, ideas about how people have been treated in the past in clinical trials and research, obviously certain demographics that we have to be very cognizant about. And so we have to take very good care. And I do think that we've moved to a way where the ethics of these things comes front and center. But that doesn't mean we don't have to always be thinking about those types of things. And of course, the risk of placebos and all those things come into play when people are deciding whether or not to do a clinical trial. But overall, I think it's our way of moving things forward. And if you came to a meeting for the Lupus Foundation, you're probably the type of person who's at least interested in thinking about these types of things. So I hope you got something out of this. Obviously here for more questions.
Once again, exactly on time. It's amazing.
So we do have some questions that I was just going to share. So first, for Dr. Belmont, are there any holistic or dietary things that help with kidney disease?
Yeah, that's a great question. And there's that cliche, you are what you eat, and there's some truth to that. But the short answer, there's no specific food you have to eat or that when you were to consume it, that you can guarantee you'll protect your kidney. Within that said, things that are bad or being overweight, generally speaking, having diabetes and blood glucose, sugar problems. There's some data that if you take too much protein, it could create some stress on the kidney, so modest protein intake. If you have some degree of kidney failure, your body may be predisposed to water retention, so you want to minimize salt. Similarly, if you have partial impairment of your kidney function, you may get a high blood potassium, which is adverse on your kidney. So what I generally recommend for my patients is to educate themselves about heart healthy diets, because lupus patients also have an increased incidence of coronary issues and increased incidence, sadly, of heart attacks and strokes. So an American Heart Association favorite diet, Mediterranean diets, low salt, low potassium, modest calories, moderate proportions. You don't want to have a high and be overweight. Unrelated to the kidney, there's one food that there was reports about alfalfa sprouts causing anemia. So I make this recommendation to avoid alfalfa sprouts. Generally not in person's diet. Sometimes they're food or salad. Low salt, low potassium, and a general heart healthy diet.
You're going to have the generic ones. Is that okay?
That's fine. I'm sorry.
I can just add, we have a lot of literature outside on nutrition and some of these questions that you may want to pick it up on your way out.
Thank you, Renee. And the books were courtesy of NYU Langone, so we should check it.
My doctor wrote it.
What are the treatments for lupus alopecia, and is there an ointment that's best for skin discoloration?
So alopecia as part of lupus in general is kind of treated in the same way that we think about treating rashes, because it really is an inflammation of the skin, obviously that then affects the hair follicles. And so when we think about those types of medicines that Dr. Belmont brought up, all of them can play a role in alopecia. It's just that some of them work for some people and some of them don't work for other people. And so we think about those milder medicines, even like the hydroxychloroquine, the Plaquenil, works for some people. And other times we have to step up to some of those immunosuppressants. One medication that we just briefly, Dr. Belmont kind of pointed out, that was one of those two new medicines that we were recently approved for non-nephritis is that medicine called anifrolumab or Saphnelo. And I bring that up because one of the things that it's been shown to really work well for are the skin manifestations, including hair. So sometimes when I see a patient, if they have really bad skin, I might reach towards that a little bit sooner. There's been some research outside of lupus, but for other autoimmune hair loss with a class of medications that's approved now for rheumatoid arthritis, You may see commercials for like Xeljanz or Rinvoq on TV, and another medication that's in the similar class that's actually been approved for alopecia areata and hair loss and those types of things. And there is some thought and consideration that those medicines might work well for lupus hair loss too, but hasn't been studied yet. But you know, those medicines are being studied in lupus in general, so we might get an idea about those kind of going forward. Topicals, you know, I think a lot of times you probably always know about topical steroids. Obviously, a lot of times people will do injection steroids when people have hair loss, and they're not pleasant, and they're usually like a ton of them, but they actually really do work for a lot of people. And then there's actually a topical version of that same type of medicine I was just mentioning, the ones like the Rinvoq and Xeljanz. And there's a topical version of that is approved and that is used for rashes, and I have seen used for hair stuff recently. So
Thank you.
a lot of forward movement.
Dr. Belmont, I know you touched on this, but can you discuss the relationship between high blood pressure and lupus nephritis a little more?
Sure. In combination is very adverse. So the general public that has high blood pressure, unrelated to autoimmunity and lupus, they have a higher incidence of kidney damage and kidney failure. So if you have high blood pressure, again, unrelated to lupus, your doctor is going to want to give you a blood pressure lowering drug. Because in the face of hypertension, it damages your heart muscle, makes it thicken, it can lead to heart failure, it can increase your risk for stroke and heart attacks. But also, it presents the kidney with blood under higher pressure. And again, all those filters, just having that image in your mind, those filters become damaged in the face of high blood pressure. So that's why if you have lupus and you have kidney inflammation and you have any amount of elevation of your blood pressure, then you need to be on a drug that can lower the pressure. That can include those ACE inhibitors and those ARBs that I mentioned. But to the degree your blood pressure is resistant to that, you may need a second and a third drug. But just to make the point, even if you don't have high blood pressure, if you have that protein in the urine, you should take a drug to treat the protein. But if you have lupus in the kidney and high blood pressure, that's a double whammy, and you definitely want to bring your blood pressure under control. That's an example where a low salt intake, a weight reduction, being as close as you can be to an appropriate weight, along with the drugs to lower your blood pressure, are important.
Dr. Saxena, this is a question about T-cell therapy, and it's obviously on topic right at the moment. And trials, any ideas about pro or con participating in it?
Yeah, so the CAR T-cell therapy is obviously everybody's super excited about it. So the basics for anybody who doesn't know what this is essentially there's a type of cancer treatment that's used where you can use your own blood, kind of genetically modify it, put it back in you, and that new blood has these types of cells called T cells that then target a certain cell. So in cancer, it targets cancer cells, and it's been really beneficial to wipe out those types of cancer cells. So now the idea is, can we do that for lupus? And the type of cell that's being aimed at is the cell that creates antibodies. So we call those the B, or the precursors of those are what we call B cells. And so the idea is you take somebody's blood, you put this, this gene in them essentially that allows them to create these T cells that then target their own B cells. And the thing about it, though, that makes that always makes us have to pump our brakes and just remember that it's very intensive treatment. It's not necessarily something that everybody needs to do. But because what happens, at least as of now, the plan is you're going to go into the hospital. They're going to give you chemotherapy, like real deal chemotherapy, to wipe out your immune system. Then you put in the blood, and then it repopulates itself slowly. But when it does, not only have you wiped out all of those B cells, but what they've shown so far, keep in mind, this is a total of 8 patients in the world. But those people long-term so far have not had their lupus come back. People are throwing the term cure around. Let's not go crazy about that yet. But this is the longest lasting treatment that we've seen. The trials that are coming, so now, of course, obviously everybody's super excited about this. drug companies are super excited about this. They already make these types of things for their cancer patients, so they've already got the infrastructure to do this. So they're like, oh man, we're gonna do this. This is gonna make our money, which again, we appreciate as doctors, but we know we have to remember that everybody's moving very quickly on this and we wanna be a little bit cautious. Now, there's a bunch of clinical trials that are being started in this in various different manifestations, kidney disease, non-kidney disease. The good thing is that we're starting slow, small number of trials, small number of people in the trials, very close monitoring and very specific into who's going to get into these trials. So right now, they're looking for the sickest of the sick, the people who have failed multiple medications, still doing poorly, on high doses of steroids and nothing is working. But these people exist, and then what we're going to happen is if this works and it really works well, then the main thing, of course, is the safety, right? Is this safe? And if it is, which it has been pretty safe in cancer, and the idea is that they think it'll be more safe in lupus because a lot of the side effects that people get with that therapy in cancer are related to the cancer itself. So if it is safe, then maybe you do broaden it eventually and make it not just for the sickest of the sick. Well, first we've got to figure out, giving that chemo, is it safe? Using this drug, is it safe? And seeing what happens. So we're a ways away, but the trials are here. So, you're going to be hearing about it and people will be talking about it.
Thank you. All right, so we have time for two more. Dr. Belmont, someone's talking about being prescribed lisinopril while taking Paquinel and wants to know does it make a difference for lupus nephritis?
Yes. So just repeat, almost anyone and everyone with lupus should be on hydroxychloroquine, which is Paquinel, for a host of benefits. And that drug, hydroxychloroquine, when combined with steroids and for example, the mycophenolate, improves kidney inflammation. But if you have protein in the urine, again, normal is 200, you get concerned even at 500 or 1,000 or 1,500, you want to take a medication that reduces the protein passing through the kidney. One family are the ACE inhibitors, and one of the most commonly used drug is lisinopril, which is Prinavel and Zestril. So that's a good combination. I made some mention that once you're pregnant, that drug should be stopped. It doesn't cause birth defects such that immediately it's an issue, but once the baby is growing at 6, 8, or 10 weeks, you don't want that drug to be consumed because then it can pass through the placenta and adversely affect the baby. So generally, someone is reliably has their periods, is trying to conceive, and they're on a lisinopril, we encourage them, once they're late for their period, to do a home pregnancy test, repeat it. If it's positive, they can then notify their doctor, and then the lisinopril can safely be stopped.
Thank you. And then this is, as we know, many people with lupus have other autoimmune conditions. Are there any clinical trials that are looking at multiple autoimmunes, or are they all specific to lupus or one condition?
Yeah, that's a good question. As of now, they're pretty much separated. I think they really want to get homogeneous populations because, as we talked about, it's already hard enough with lupus because everybody's so heterogeneous, and then if you start throwing in other diseases. There have been some talks about doing what they call like basket trials, essentially, where they look at a drug in different populations at the same time. From the scientific standpoint, they're separated. The patients are separated, but in terms of opening it up to people, it opens things up to more people with different diseases. So that might become something that's more common going.
I'd like to thank both of you again. For any questions we didn't get to, we will capture them and send them out to everyone. One thing that was touched on is one of the things we talk about at the Lupus Foundation all the time is patient empowerment. So I think, being educated and having information, a lot of what Dr. Belmont shared is really great information to take back to your provider to have those conversations with. And then clinical trials are a fantastic way to help advance research. And we have 3 people with us tonight that are part of our Lupus Research Action Network and ambassadors for the Lupus Foundation patients. So I'm going to ask Judith, Burkia, and Brittany to come on up. So I've just asked each of them tonight to introduce themselves, share a little bit about the lupus story, and then we're going to open up, have a little bit of conversation and talk about, why they, have they participated in clinical trials, what their thoughts are on clinical trials, and then we'll open it up for questions. So anybody volunteering to start?
Sure.
So this is Julie.
Hi, everyone. I'm Judith Mills, and I suffer from lupus. I was diagnosed at the age of 16, 1999, when, nobody really knew much about lupus. And it's been a struggle. I've had some ups and downs, and I'm just happy to be here to share my story.
Brittany?
Hi everyone, I'm Brittany. I was diagnosed with lupus when I was 22. It was a pretty complicated journey. I had symptoms since I was 10 years old. I went through a lot of struggles because I think back then really pediatric rheumatology was what it was today. And so there wasn't a lot of research done on lupus in pediatric patients. So it was really hard to get a diagnosis. And then as I went on, I had a lot more symptoms, suffered a lot of complications. I had sepsis. And so later on, finally, after college, I was diagnosed with lupus just after having a multitude of symptoms. So, it's been a journey, like I think it has been for all of us, but thankful to be here and be able to share my story and be able to advocate for the rest of the lupus community.
Hey everybody, my name is Berkia. Unlike these young ladies, I'm sure I had symptoms very early on, but they weren't quite pieced together. It was just some things here, some things there. It wasn't until I had my first miscarriage that I was diagnosed. My neurologist is the one who put the pieces together, and it was because she had another patient who was having similar symptoms as I was and also had a miscarriage. So that's kind of how I got diagnosed, and I was in my 30s by that time. Yeah, and it was in 2011. I had no idea what lupus was, had heard, it was just like, what is that? And I think even in being diagnosed, while I was happy to know what it was, I was kind of in denial because all of the information that was kind of out there was very extreme and it didn't really speak to what I was experiencing for the most part. So, yeah, I'm hoping that somebody kind of does research around lupus and pregnancy because that was really a big part of my story early on. And it seemed like every time I got pregnant, the lupus got worse. And so definitely connected to my hormones. And yeah, I'm waiting for them to like really do some work around that stuff.
Some doctors here to take definitely take chat with Renita afterwards. So for any of you, in terms of clinical trials, what were some of the hesitations you had before, when you started thinking about it?
I would say for me, when I got the lupus diagnosis, I was like, yay, and then I was like, nay, because I was put on so much steroids. So, I was reading a lot of books, and, my target was remission. So I was just constantly searching for answers. And, I came up across the University of Michigan at the time. They were doing some research, and I was like, right away I wanted to, be a part of it. I was just always optimistic, and I was also in the biology field. So, clinical trials is like the answer to everything because that's how we have our OTC medicines because, we had clinical trials. So I was very positive about it.
Yeah, well, like you, I also have a background in biology and public health, so I'm a big advocate for, stressing the importance of clinical trials, participating in research. And I think for me, I've never been in a clinical trial myself because I was the one that asked the question about multiple autoimmune diseases. So I also have ankylosing spondylitis. So that complicates things. And I think it also complicates things when it comes to my medication regimen because we have to treat both diseases at the same time and try to tackle both of them. And one flares and, my double-stranded DNA levels go up. So that's the priority, treating the lupus. And then my back really hurts. That's the priority, is treating the AS. So it's always a balancing act there. But I would absolutely participate in a clinical trial if I could, if there was one that fit my criteria. But I think the most important thing is when considering a clinical trial is you are a piece of the puzzle that represents patients that are affected by lupus. So we need a diverse population of patients in clinical trials to make sure that we're representing those that are affected by the disease. You know, what, it could be age, age, gender, ethnicity, race, anything. Also your symptoms come into play too. So if you experience a certain set of symptoms, you're representing that patient population that also has those symptoms as well, since it is very, it's very complicated, very, as you said, heterogeneous. So I wish I could participate in the clinical trial, but there's also other types of research you can participate in too. Last year I signed up for this biorepository registry where basically any sample that you take, like we get our blood taken every 3 months, that is used to study the different markers that are associated with autoimmune disease. So it helps develop these medications that are more targeted. So there's multiple ways to participate. There's also real world evidence using, your electronic health records just to understand your quality of life. So even if you can't qualify, there's other ways to get involved as well.
Oh, boy. I think I was probably in high school the first time I was ever exposed to what clinical trials were, but it was from a historical standpoint, so it wasn't the most positive kind of conversation. And so from then it kind of was like, not doing that. But as now, I mean, people have asked since I've been diagnosed, and I've usually said no until more recently, being a part of Lupus Foundation of America and then becoming an LRAN ambassador. I think my outlook is very different now. One thing that's personal for me is, lupus impacts women of color, which I am a complete representation of. And in learning that one of the medications that I absolutely did use, which was Benlysta, I did, for a couple of months go to the hospital and do the infusions, and then I was doing the injections at home, and it did not work. But it didn't work because women of color weren't really participating in the study. So here we have this great medication, but it doesn't work for people who represent what I look like. And knowing that I've used it and it didn't work. So now at this point, I'm like, well, how do I help? Because yeah, we might not find a cure for me, but the young people that are coming behind me, they definitely can be impacted by this. And so I actually saw my doctor this week, and she was talking about the trials that are coming. And one part of the conversation was, you might not be sick enough to participate. And so that was kind of disappointing. But that's usually kind of how this journey has been for me. Like, I'm not sick enough. I haven't had kidney involvement. My joints are killing me, and I feel, even right now, I feel like crap. But it's been a rough road in trying to figure out where you fit, because it impacts everybody so differently. So I'm open to what that looks like, but I do feel like LFA has created something called RAY. If you don't know about it, please tap into it. So RAY is a database where you can go and just input information. You talk about what medications you've taken. It's basically a bunch of demographic information, and it'll help them do research. So, I mean, no, you're not going to an office to get your blood drawn or anything like that, but you're sharing information about your specific experience, and that does help, and actually I went back on there recently because some stuff had changed, and I wanted to add it, and we all know medications change for us, we change underpants sometimes, right? Some days we're not on steroids. They were talking about weight loss, and I'm like, if I could stop taking steroids, maybe I could stop eating. But so yeah, that's a big way to participate if you're not quote unquote sick enough.
Yeah, I think everybody's raising an excellent point, which is, when you think about advancing research, there's many, many ways you can be involved. One of the ways that's very simple is becoming an e-advocate. You can sign up to be an advocate online, and then when any legislative issues are happening on the federal or state level that affect lupus and funding for research, that's a way that you can just literally click a couple of buttons. It's that turnkey. Rakia and Judith were with us when we went to Capitol Hill a few months ago. They went out and met with the legislators, so that's a way to help advance research, participating in RAY. The information that is collected is de-identified, so nobody's going to know it's you. But researchers need access. One of the things that we're focused on at LFA is patient-focused drug development. We really need to be having conversations. I think Dr. Saxena mentioned how there's some things that are really just not measured in numbers. How do you feel? How do your joints feel? Fatigue. People use that word fatigue, and sometimes your friends and family go, "Oh, I know I'm tired." Nope, not this time.
Not this time, sorry.
But we can- a lot of things that are not as quantifiable, but we have to have patience as part of the process. Does anyone have any questions for our patient panel? There's information out on the table next to the other information that's available. But I'd like to thank our patient panel, and then I will just finish up the program. I have 4 minutes if I want to stay on time. I gotta really get started. Questions on. So, we're really excited to be here today. We're so excited to have NYU as our host. And to our sponsor, Artemia, who hopefully you've met outside. But I'm just going to talk a little bit about the Lupus Foundation of America, our mission, and our resources. So our mission is dedicated to improving the quality of life for all people living with lupus through programs of research, education, support, and advocacy. We do this through our 3 pillars: research, care and support services, and advocacy. Everything that we do really focus on our strategic outcomes. So we want to reduce the time to diagnosis. And we didn't spend a lot of time talking about that, but we know that a lot of people have stories where it's taken, on an average 5 or 6 years, multiple doctors to get that diagnosis. We talked a lot tonight about how we get to medications, but for 45 years, very limited medicines on label for lupus. So we know that that's something we have to work on. We want to expand direct services for treatments and care, and to do all this, we have to raise lots of money. Next slide. So these are some resources for you. If you're not familiar with them already, I highly encourage you to look at them. Our National Resources Center on Lupus is a website where you can get articles, you can get podcasts, you can download resources, principles. The content's updated all the time. They're a curated track, so if you're newly diagnosed, which somebody indicated on their card, you can go in and say, "I'm newly diagnosed," and they'll recommend some articles that way. If you're a caregiver, you can go in that. If you're interested in lupus and pregnancy, and we're updating the content all the time, so I highly encourage you, if you have a question, just go in and look at the National Resource Center. Next. Part of what's included in there is our expert series. We have a series of podcasts. I think there's 5 or 6 seasons. So you can go in and look, literally experts from around the world talking about different topics. So you can go in and search by topic if there's information you're interested in. Education programs like this one. Our next one will be on, wrote it down, June 29th. It's online, it's virtual at 1 p.m. and it's on finance and budgeting because we know our presentations are not just on medical topics. We know that lupus affects every aspect of your life. So you can sign up for that online, and we'd love to have you join us. Lupus Connect. How many people here participate in Lupus Connect? It's an online community of support. It has over 18,000 members around the world. And you can go on at any time and you can find out, you can connect with other people. You can search by zip code to see if there's people in your area. If you're interested in asking questions, I find it a very warm and supportive environment for people just looking to talk to others with lupus. One thing I hear repeatedly from lupus patients is, even if I have a wonderful, loving, supportive environment, it's still not the same as talking to somebody else who's going through it. Support groups, they're currently all operating online, but we've had one that's been operating here for many years. And so that's another way that you can meet with other people and find a community. Our health education specialists are available in English and Spanish. You can reach them through our website, or there's a phone number. They can talk to you about insurances. They can talk to you about if you're looking for a doctor in an area, all kinds of things. They're amazing people. They're very caring, and they're one of our great resources. Take Charge is a 12-week email series for people who are diagnosed with lupus. We know that when you get a diagnosis, as Judith said, she said yay, and she said nay. You have emotional reactions, you have physical reactions, you have financial reactions, and at the same time, you have to learn a whole new language. What are these medications? What are these tests? What do these numbers mean? So this is kind of empowering you to learn more about lupus as you're starting your journey. Self is a resource for you. You can go on and you can track your symptoms. A lot of times, if you're going into a flare, it doesn't always coincidentally happen when you're going to see your physician that week. Might be a month, might be 2 months. So this is an opportunity where you can manage all your information so that when you go in to see your care team and they ask, how have you been doing? You can pull up yourself on your phone and just say, oh, gee, a couple weeks ago, I noticed I had swelling, or I noticed I had a fever or chills or what have you. And again, this is entirely for you to manage your medications, have all your information in one place. Ray, Verkia talked about, research accelerated by you. So again, this is a great way that you can participate in accelerating research by sharing your information. It is de-identified, so nobody's going to know it's yours, but you can provide information that researchers can use. Be Fierce, Take Control. We just launched our second iteration of this. This is a social media campaign designed for 18 to 25-year-old Black, African American, and Latina women because they're at higher risk. And again, in the idea of empowerment, I've heard a lot of people, particularly when they're in their teens or early adult life, when they go in and they say, I have joint pain or I have issues. Well, do you play a sport? Well, do you dance? Oh, you're overweight. So that there's can be a dismissiveness of it. So we're trying to empower them to understand what signs and symptoms are so that they can have great conversations with their care team. Go next. So how can you help? You can advocate with us. I talked about joining as an e-advocate. We also go to DC once a year. We were up in New York State and Albany at the Capitol. So that's one way you can engage with us, and all your friends and family can engage with us that way. Walk to End Lupus Now will be coming. Wow, those dates are really long. They're all in October. Jessica, my colleague, is the New York City Walk Manager, the Development Director. We'll be down at the Seaport on October.
We'll be there on October 7th.
It's a great day. How many people have been out to the walk? Excellent. Usually have a couple of thousand people down at the Seaport, and it's an amazing day. So that's a way you can get engaged with us. This is how you can reach us. We have all this information outside. And how did I do? Am I close? 8:02. Sure. I love that I'm part of the talk. On the agendas that I handed out, there's a QR code for the survey. We'd love to have you fill it out. You don't have to do it tonight. If you want to, you can. And we'll send it out again with the link. But we always want to hear from you so we know how we can continue to grow to meet your needs. So thank you, everybody.
Thank you very much.